As you can see, answers B, D and E are right. A is wrong because primary tumor size is not the thing that limits the patient's prognosis. If you can bring him to R0 resection, he can even be in a curative situation. And C is highly debatable, as we talk later on. Neoadjuvant chemotherapy could be an option, but if you give neoadjuvant chemotherapy, it should be with carboplatin and paclitaxel, and this chemotherapy that is shown here as a chemotherapy typical for breast cancer. Computed tomography of the abdomen is the investigation of choice for monitoring and for diagnosis of recurrence. In the primary workup, it's considerably inferior to vaginal ultrasound. At this stage, computed tomography is only relevant for evaluation of the abdominal lymph node status, but this is not mandatory before an operation. If ovarian cancer is suspected, confirmation of the diagnosis by laparoscopy should not be performed, as port-site metastases often develop at the trocar insertion sites only shortly after the operation. If laparoscopy has inadvertently been performed, the trocar insertion sites are resected at the subsequent laparotomy, which should follow within a short period of time. Cystoscopy and rectoscopy are usually also performed preoperatively to evaluate the operation site in the small pelvis. The next slide shows the 2003 FIGO classification. Stage 1 tumors are rarely found. Stage 3C is undoubtedly the most common. Now we come to surgical treatment. If there's a strong suspicion of ovarian carcinoma, laparotomy through a midline abdominal incision should be performed, as this is the only way to ensure the best possible exploration of the abdominal cavity. Pelviscopy, on the other hand, does not allow adequate inspection behind the liver, along the diaphragm and of the lymph nodes. According to the AGO guidelines, which is the German gynecology-oncology study group for treatment of ovarian cancer, the following steps are necessary. ESMO, which is their European equivalent, and ASCO, the American counterpart in this case, are pretty much the same. On entering the abdomen, samples for peritoneal cytology should be obtained. The entire abdominal cavity should be inspected and palpated. Biopsies taken from all suspicious sites and multiple peritoneal biopsies taken from macroscopically unremarkable sites. Both ovaries must be removed, taking care in early stages not to rupture any cysts present. Hysterectomy and at least infracolic omentectomy should be performed, plus appendectomy in the case of mucinous or unclear tumor types. The pelvic and para-aortic lymph node should be removed, the latter up to the level of the vena cava at the junction with the renal vein. It has been shown in more than 20 studies that resection of all present tumor is crucial for the patient's prognosis. To ensure that this is achieved, an ambitious approach should be used for the surgical treatment. This can mean that, in addition to the steps outlined above, for example, partial colon resection with colon anastomosis, if necessary protective stomas, partial liver resection, partial diaphragm resection, splenectomy, cholecystectomy, and partial or complete cystectomy, ural resection with reimplantation, and artificial urinary drainage operations might be needed. Tumors are considered inoperable if there is a marked involvement of the small intestine or if the mesenteric root close to the celiac trunk is involved. At experienced operative centers, complete cytoreduction can be achieved in up to 85% of the patients. The next slide shows the results of a meta-analysis of pooled German data on how the quality of the surgeon has an impact on the patient's survival. The graph shows that it makes a marked difference for the patient's overall survival whether a zero resection is performed or whether, in the red curve, there is even only a minimal amount of residual tumor. This is particularly important, since it was assumed in the past that it was sufficient to aim for residual tumor less than 1 cm. The curve for minimal residual tumor is in fact not very different from the one for macroscopic residual tumor than 1 cm. To illustrate that even larger upper abdomen interventions are justified, let me show you a trial comparing patients with advanced stage ovarian carcinomas that were retrospectively stratified in diaphragm surgery versus none. As you can see, the patients do largely benefit from the extended surgical interventions, which gives us better PFS and OS. Now let us look at the question of lymphadenectomy. The current rule is that this should be performed if a zero resection in the remaining abdomen is possible. However, until now there is no clear evidence supporting this procedure, since the available data do not show any positive impact on overall survival. Randomized prospective studies on this area are in progress. If a zero resection is not possible, only the lymph nodes which are enlarged to palpation and thus suspicious should be removed. In stage 3 disease, lymphatic dissemination has already taken place in a majority of patients. In very young patients who may still wish to have children, an organ-sparing procedure only appears justifiable in patients with stage 1, grade 1 disease. In this case, it's also possible not to perform adjuvant therapy. Let's now have a look at the only available prospective data regarding lymphadenectomy. In the big international lymphadenectomy trial, close to 300 patients were randomized in lymphadenectomy versus none. While as you can see there is a significant advantage in PFS regarding lymphadenectomy, there's almost no difference for overall survival. But main point of critique of the study is that the macroscopic complete resection was only achieved in 37% of patients, which is considerably lower number of what we can possibly achieved in top centers with 85%, as you heard before. So it must be suspected that the overall survival in a completely debulked group would have been significantly better. Prospective trials looking into that issue have already finished recruiting, so that the results are due to be released soon. The next big section focuses on adjuvant chemotherapy. The two Kaplan-Meier curves on this slide show you the absolute difference that adjuvant chemotherapy can make. While adjuvant therapy gives you a better relapse-free survival by 11%, overall survival is improved by 8%. For comparison, this is slightly more absolute difference that an anthracycline taxane-based regimen can hope to gain in an adjuvant medium-risk breast cancer setting. Please do note that the regimes used in the setting are not state-of-the-art, and with modern regimes an even bigger difference is probable. Let me now talk a little about neoadjuvant chemotherapy versus primary debulking surgery. As I said before, in Germany there's a strong trend in favor of doing debulking surgery first. Internationally, there's a strong discussion raging whether chemotherapy should be given first in order to shrink the tumor and then be able to maybe do easier surgery. While some data on this topic exists, this data is highly controversial. A randomized Phase 3 trial was conducted by Vergodi and all and published in the New England Journal, where patients with suspected ovarian cancer were randomized either to primary surgery or to neoadjuvant chemotherapy with carboplatin paclitaxel and then surgery. The authors found no difference in PFS or overall survival between both arms. Peri- and postoperative morbidity tended to be fewer in the neoadjuvant arm. While one might guess that this settled the question in favor of neoadjuvant treatment, there are some major weaknesses of the study. As critics argue, the complete resection rate was only 19% in the overall cohort, which is, as we already heard, the most important factor. In addition, some centers achieved optimal cytoreduction in only 3% of patients, which raises the question if the surgical expertise was high enough to participate in an ovarian cancer trial. The average OR time of 165 minutes further strengthening this point, as if I tell you that the median OR time in our center is around 8 hours. According to local guidelines, neoadjuvant therapy should be used only if the patient's general condition does not allow upfront debulking, or if, for example, in CT scan factors exist that make a complete resection highly unlikable, e.g. gross infiltration of the mesenteric root, intrahepatic metastases, or strong pleural carcinosis. Another factor would be a FIGO 4 stage. Here you see what trials led us to today's standard adjuvant treatment. On your left-hand side, the GOG 111 study with 410 patients. On the other side, the OV10 trial with 680 patients. Both studies confirmed that the cisplatinum-taxane combination is superior to standard of those days cisplatinum cyclophosphamide. In both trials, the 5-year survival rate was improved by 11%. The relative difference in survival is due to the fact that the GOG study did only include non-optimal debulked patients, while the other study included also optimal debulked patients, which, as you have learned in this lecture, tend to do a lot of better in overall survival. The next slide shows you the result of the AGO3 trial, a German study that had shown that carboplatin is equally effective in ovarian cancer, while having a considerably better toxicity profile, particularly as regards renal damage, nausea and vomiting. This regimen was accepted as standard adjuvant treatment worldwide. Unfortunately, all efforts taken within the next decade to improve this regimen were futile. Numerous studies have shown that the addition of a third chemotherapy drug, e.g. gemcitabine, does not confer any additional survival benefit while substantially increasing the toxicity of the treatment. The same applies to higher dosages of carboplatin and paclitaxel and to more than 6 courses. A promising option regarding the improvement of conventional chemotherapy was presented on 2012's ASCO by a Japanese group. There, the use of dose-dense and dose-escalated paclitaxel compared to conventional given Q3 weeks paclitaxel did improve progression-free survival and overall survival significantly. This was gained with a moderate increase in toxicity. Unfortunately, the ovarian carcinoma patient population in Japan is differently composed to that other study collectives, which is why those results can't be easily transferred to other regions in the world. But results of 2 European phase 3 studies investigating this interesting approach are pending. Let me now turn your attention to targeted therapy, especially the use of anti-angiogenesis. The two flow diagrams show you how the big 2 phase 3 studies with bevacizumab were concepted, basically adding the bev, as it is called, to the standard carboplatin paclitaxel therapy and continuing it for a year after the end of the chemotherapy. The next slide shows you the main problem when we talk about ovarian cancer and bevacizumab. While there is a significantly advantage for the addition of BEV, it is numerically small, and the question is if 3 to 4 months of PFS improvement, as you can see in both graphs, justify the enormous expenses that the use of the drug implies, especially to no survival benefit exists. While there are now overall survival results for both studies regarding the complete population showing no significant difference, there are positive results in the high-risk group of the ICANN 7. This means the group that has not been optimally debulked or had shown metastases outside the abdomen. As you can see, there's a significant overall survival advantage in the BEV group. But please consider that this was an unpreplanned subgroup analysis that should therefore not be overrated. In our team, we came to the conclusion that we use bevacizumab in this patient group and use a conventional regimen if no minimal residual tumor is present. Let me add that the main concern of the usage of BEV did not occur. There were no more bowel perforation with the use of bevacizumab. While BEV was the first targeted drug to show clinical benefit in advanced ovarian cancer, until today several other antibodies and multi-kinase inhibitors have shown effects, but major breakthroughs have not been yet made. The main problem here seems to be the selection of patients who will benefit most from each drug. While several models ranging from genetic profiling to markers found in clinically routine have been proposed, no predictor has made it yet into clinical routine. To conclude adjuvant treatment, while regard to chemotherapy, a platinum-containing regimen is today's standard for adjuvant treatment. In the past, cisplatin was a drug of choice. Now carboplatin should be favored due to the better toxicity profile. It is not yet clear how many courses of chemotherapy are needed in early-stage disease. The data on this are heterogeneous, but the consensus is that at least 3 courses of platinum monotherapy must be given. Whether paclitaxel confers any additional benefit is questionable. From stage 3 onwards, and this for the majority of patients, combination with 6 courses of carboplatin and paclitaxel IV is a standard treatment. Nevertheless, numerous ongoing clinical studies are currently investigating the use of small molecules, either in addition to the standard therapy or as maintenance therapy after completion of the standard therapy. Results are pending. The addition of bevacizumab should be considered in patients with residual tumor after surgery. Bowel anastomosis are no exclusion criteria for the use of BEV. A new promising attempt makes use of the above-mentioned fact that in ovarian cancer cells are often BRCA mutated. This might offer a treatment approach for targeted therapy with, for example, PARP inhibitors. We will hear about them soon during the palliative chemotherapy section. Now let me say a few words about intraperitoneal chemotherapy and HIPEC, which is hyperthermic intraperitoneal chemotherapy, meaning that the chemotherapy agent is heated during administration and then applied to the abdominal cavity. The argument given by some oncologists is that the intraperitoneal administration, either during the operation or postoperatively via catheter systems, delivers the chemotherapy directly to the site of the tumor. However, only a few studies have been able to show a small survival benefit over intravenous therapy. Moreover, this was achieved at the cost of very high toxicity, complication rates so that only about 40% of the patients were able to receive the intra-abdominal peritoneal chemotherapy as planned. Catheter complications or infections appear to be very common. In addition, direct comparisons with the current standard regimen of carboplatin and paclitaxel have yet to be performed. But nevertheless, HIPEC is a widely investigated option, and especially IP chemotherapy is widespread in the United States.